This is Professor Yael Rafaeli, a thoracic surgeon and my collaborator. She wants the best possible care for her patients, and she uses the most advanced technology to get this care. But there are still procedures that she cannot perform with surgical robots, that she has to perform openly, and she cannot abandon the see one, do one, teach one paradigm of surgical training. In robotic-assisted minimally invasive surgery, a surgeon controls a pair of robotic manipulators to control instruments inside the body of a patient. Now, over 1 million of these procedures are performed worldwide in a variety of applications, but still there are limitations. The force feedback is limited and training is still not optimized. Now, you may think that the best solution is to take the surgeon out of the loop completely and use the robots because of their advantage in precision and access to information, but the surgeon is really needed because of the ability to make decisions in arbitrary situations and because of their advantage in movement and manipulation. The way we address this question is again going back to very basic experiments in interaction with elastic objects. So again, we ask participants to perform movements, probing movements into the elastic object and apply stretch stimulation on their fingertips or not. By comparing pair of objects and using psychometric curves, we can infer the augmenting effect of the stretch of the fingertips on the perceived stiffness. And we actually found that stretching the skin of the fingertips causes an immediate illusion of touching a harder spring. So it is enough to touch the object even once to experience the illusion. And in the same time, when we're looking at the grasping forces, we see that the grasping forces become stronger and stronger with each repeated interaction with the elastic object due to the stretch, which means that they slowly and gradually form an internal representation also of touching a harder object. And these two effects on the perception and the action are actually separate, and there are two separate processes. So as we go about designing the controllers, we have to take into account the perceptual effects and the effect on action separately. Further exploring this illusion, we actually found that this illusion of touching a harder object is robust to noise, but weakened by the presence of visual information. I started this talk with saying that we need a model of the surgeon. But in fact, if you take together everything that I told you during this lecture, we actually lead to the conclusion that one model is not enough. And we actually need several models that describe separately the perception, the action, the adaptation, the skill acquisition. And the sensory motor system of the surgeon is too complicated to describe with just one unifying overarching model. And the challenge is how you are taking these separate models that are relevant in each of the contexts and use them in order to improve all these different aspects of a system to the surgeon that I started with. The key is identifying within each of these additions that we can add from the surgical robot to the user and use the appropriate models. So it's a task of matching between the proper level of description of what the brain of the user is doing to control the motion and process information and the augmentation that you want to apply, whether it's force feedback or assistance or if you're trying to develop a new training algorithm. Each of them would require their own model. So the last thing is thank you to the team who actually did all the work that I just told you about, and thank you for listening, and I'm open for questions.